Hello, everybody, and welcome to the Hughes Clues chronic coronary artery disease, chronic stable angina, and other things heart. I think before we begin, and I am going to divide this into two different categories. We're going to first, in just a few minutes, talk about coronary artery disease and chronic stable angina. But before I begin anything, I just kind of want to remind you about the heart's anatomy. And if you'll notice, for our heart to go on, and really for our body to go on, the cells need oxygen, and the heart is responsible for pushing blood around the body so that those cells get oxygen. But just like that flight attendant that says to you, in case of an emergency, put your oxygen mask on first and then help others, well, it's the same with the heart. The heart muscle itself must have oxygen. And so therefore, the heart is going to ensure its survival by ensuring that it gets its oxygen first. If you notice here, the coronary arteries are right there in the aortic root. That means this is the aortic valve, and so immediately after the blood is ejected out of the left ventricle, then those coronary arteries are there to snag that blood flow right away. And what happens with coronary artery disease is these pipes that you can see that deliver blood to the heart muscle, these pipes become blocked, and therefore it is difficult for them to deliver the oxygen or the blood, and therefore the oxygen to the heart muscle. So really, when you think about heart, it's a supply and demand issue. And as I said, we're going to first talk about coronary artery disease and chronic stable angina. So let's do a patient scenario so you can kind of get a better sense. And we've got a 55-year-old female presents to the clinic with a complaint of dyspnea, and as you look at this 55-year-old female, I want you to try and identify the major risk factors that may accelerate the development of atherosclerosis and place her at risk for cardiac issues. And then because it's always, these risk factors are always divided into either modifiable versus non-modifiable, determine which is the case with the risk factors you determine. And when we look at the risk factors, we know that some big risk factors or the major risk factors are hyperlipidemia. And when I say that, that's just a fancy term for high fat in the blood, and that includes the LDL, the low density lipoproteins, and the triglycerides, as well as diabetes, smoking, and hypertension. Those are the big or the major risk factors. Now, we all basically have plaque formation. If you, I think there's been studies that have shown that even 4-year-olds have or have some plaque formation, but how fast that plaque forms is greatly dependent on our lifestyle choices. And so in individuals that are obese and who have high levels of lipids and cholesterol, and it would stand to reason that they would because those are high calorie content food, and those and that would make sense how that would accelerate plaque formation. But it's a little bit more difficult to remember about uncontrolled diabetes, hypertension, and smoking. And if you think about it, it's all about here when you look at this plaque formation, it's all about the artery lining. And as you damage that artery lining, then it makes that artery more susceptible to plaque formation. So in an individual who has uncontrolled blood sugar, that is very damaging to the inner liner of the artery. And so that will cause plaque or atherosclerosis to more quickly begin forming on the inside of the artery. And of course, hypertension is the same thing. It's that pounding or that force of blood beating against the artery wall that also damages it, causing an acceleration of plaque formation. Cigarette smoking is toxic chemicals that damage the inside lining of that artery also and will increase acceleration or accelerate the formation of plaque. And then, of course, if an individual has a decreased level of the healthy cholesterol, the high density lipoproteins, those HDLs essentially will pull that cholesterol, the LDLs, out of the inside layer here. And so if you have less HDL, then you have less help getting those fat molecules to stay inside the blood. And then we've got some other things here, homocysteine level and inability to control and manage stress and anger. Non-modifiable risk factors include age, race, gender, and family history. So when we look at this 55-year-old woman that's presented with dyspnea, we can really identify how she would be at risk for a cardiac problem because she has a strong family history of type 2 diabetes, and with her obesity and the fact that we've measured her height and weight, and so therefore have come up with a body mass index of greater than 30, that puts her at risk for coronary artery disease, in addition to the fact that she smokes 3 packs a day, rarely exercises, and drinks. I mean, basically, I've given her all the bad risk factors that can cause her to be susceptible for coronary artery disease. And when you think about atherosclerosis of an artery, well, it can really occur in any of the arteries, and I've got 3 places that atherosclerosis can occur. So you've got this big red circle, that's coronary artery disease, and then you've got peripheral vascular disease and cerebral vascular disease. And atherosclerosis can form in any one of those artery systems. It does seem to like the coronary arteries the most, and you can see that if an individual comes in with known coronary artery disease, that should also clue you in, well, they're at risk for peripheral vascular disease as well as cerebral vascular disease. And when we talk about health screening or diagnostic testing, probably the most common thing that's done with any individual that has known risk factors and complains of symptoms, the first thing that's probably going to be done is a 12-lead ECG. Now, we've talked about looking at the heart's electrical activity by placing the patient on a monitor. A 12-lead ECG means that we're going to put 12 different electrodes on one on each of the 4 limbs, and then there's going to be 8 on the chest. And when you do that, you're essentially recording the electrical activity from 12 different views. And notice that 12-lead ECG, yes, it tells you about the electrical aspect of the conduction system, but it can also tell you about the position of the heart, hypertrophy, pericarditis, and some other things here that I have listed that it would be in your best interest to make sure you read and understand that the 12-lead ECG does do more than just identify what the rhythm of the patient is in. And what I've circled here is, if you'll notice, this is how the 12-lead ECG will look. It comes in 12 different views, and again, that's just angles of the heart's electrical activity. So if you think about taking a picture of your head, you would know that if you want to get all the different views or angles of your head, you'd have to move your camera from the front to the side to the back, and that's essentially what this 12 lead does, is when you put all those electrodes on the individual, you're looking at the electrical activity from kind of around the world kind of deal. And notice here you've got 1, 2, 3, and then AVR, AVL, AVF, and then V1, V2, V3, and so on and so on. And it's not important that you know all the different leads, what their names are. It's just important for you to realize that there are 12 different angles or views that we can see the heart's electrical activity, and that the 12-lead EKG is used for a whole lot more than just looking at the patient's rhythm. And then notice that the 12-lead will also run just a long strip of lead 2 down at the bottom. Other health screening tests, because we've already discussed that diabetes and hyperlipidemia and hypertension accelerate plaque collection of plaque, atherosclerosis in the artery, well, we need to check this individual's blood pressure. We need to check the blood glucose, and it would be nice if we could do a resting blood or not resting, but a fasting blood glucose. And then look, we're going to do a lipid panel, and the lipid panel just means that we're going to measure serum triglycerides, of which it's LDL and HDL. I try and remember HDL by thinking H means healthy, so these are the good cholesterol, so we want that number to be as high as possible. 50 or better is great, whereas LDL, that's the lousy lousy cholesterol or low-density lipoproteins, the bad cholesterol. The LDL should be less than 100. If you have known coronary artery disease, some cardiologists say, well, you really should be less than 70, and that's kind of hard to do. Total cholesterol numbers should be less than 200, and then your triglycerides, they should be less than 150. And I give you all these numbers for a reason, because sometimes I don't think you're going to be asked, well, what is the normal, but these numbers may be thrown into the question. So if you kind of know what these values are, then you'll know where that patient is at. And then, of course, we already talked about this patient, specifically her BMI, which is her height and weight, and calculates a body mass index. Anytime it's over 30, then that indicates obesity. A number that's over 25 or better would be overweight. 25 to 30 is overweight, and then over 30 is obesity. Because atherosclerosis can occur in any artery, we want to assess the peripheral pulses, because that way we would be able to determine if there is a problem with peripheral circulation. Some other diagnostic studies that might be ordered on this individual are an echo. And an echo is using ultrasound and looking at the movement of the heart structures and can calculate ejection fraction. And I think I mentioned ejection fraction before, so let me just define it, and it's in the PowerPoint on the bottom in the note section of what the ejection fraction is, and it's essentially just what it is. It's how much blood fills within, or how much blood will enter the left ventricle during diastole, and then during systole, what fraction of that does the heart eject. And so on average, the heart will fill with 120 mils of blood, and then on average, the heart should eject about 70 mils of blood. And so if you did the math and you determined the fraction of what was actually ejected versus the whole volume, then it comes to 58%. And I think I wrote in there that 55, some books say 50, but 50 to 65 to 50 to 70 is a normal ejection fraction. So that will really tell you how well that left ventricle is pumping, and we can determine that by using the sound waves on the chest. Now, sometimes individuals need what's known as a TEE, which is a transesophageal echo, and this is when a probe is shoved down somebody's esophagus. Yes, it says that they're swallowed. Well, there's no swallowing involved. It's basically shoved down, which would tell you that because of a strong gag reflex, that's not going to happen if the patient is awake. So therefore, they're given a lot of IV sedation, local anesthetic, and therefore, because they're given that and they're at risk for aspiration, they have to be NPO at least 6 hours prior to the procedure, and then we want to remove the dentures. The bite block may be inserted because while the patient is semi-unconscious, well, we don't want them to bite down on that probe because that could damage it, and then you can't see the testing or the what information you're trying to get. And of course, because they're given conscious sedation, they can't drive themselves home. That's the echo, which is non-invasive, and then the echo TEE, which is the invasive echo. Those both basically get different or the same information but from a different perspective. Another test that can often be done is the exercise stress test. And essentially, you're going to ask an individual to get on this treadmill, and then you're going to have them do some exercise while stressing them. In other words, you're going to make it walk, and then you make it go faster, go uphill. And the whole point is to see is the whole supply and demand issue. How well does that coronary artery supply blood to the myocardium during a time when the myocardium is demanding more? And that's when you exercise. If you think about walking up those stairs, your heart rate's going to go up. You're going to breathe faster because you need more oxygen, and your heart is supposed to pump and deliver more blood because the heart muscle itself is needing more because its demand has gone up. And of course, there's some specifics here, 3 minutes, 6 minutes. I don't think you need to know that. You just need to know that that an exercise stress test is done to see about the heart's ability to get its supply and demand. Like there is nuclear testing and nuclear stress, which is for an individual who there is no way they can get on a treadmill, and so therefore they will give you chemicals that will essentially speed the heart rate up and do the same thing as if you were walking to see the effect of supply and demand. Well, let's say that our individual has had all those diagnostic tests done, and during the exercise stress test, the patient was intolerant of the treadmill stress, and they started experiencing worsening dyspnea and chest discomfort. The ECG or EKG, ECG is proper, EKG is commonly referred to, both mean the same, showed ischemic changes, and so therefore the cardiologist chose to stop the stress test. And so what might be the cause of the symptoms? Why would this individual have ischemic changes? Well, first of all, what does ischemic mean? It means that there is not enough of a supply. In other words, there is not enough blood being delivered to the myocardium as it needs. So you ask this individual to exercise more, to exercise harder, and therefore we need more blood carrying more oxygen to the muscle. If the individual has atherosclerosis, like what you see here, you can see that that atherosclerosis essentially decreases the amount or the lumen, which is the opening of the artery, so that less blood is actually delivered downstream to the myocardium. So here's your myocardium that needs that oxygen. You can see there's fewer red blood cells, that's fewer oxygen is delivered, less is delivered. Now when you look through a cross section, it's essentially the same thing. What should be is this big of a lumen or hole where blood goes through, and because of all this atherosclerosic plaque, you have only this size of a lumen. So it's just looking at this artery from different directions and for a different perspective, but essentially what will happen is as you look at the EKG, there is some very specific EKG changes that will be seen whenever the heart muscle is not getting enough blood and therefore oxygen. You'll have ischemic changes. We'll talk more about that in a minute. And I've put on here, we associate crushing chest pain, diaphoresis, and nausea with myocardial ischemia, but I want you to notice or note or recall or remember that women have different symptoms. This individual came in with shortness of breath, and that's very typical for a woman who's experienced ischemia if there's not enough blood flow to the heart muscle. Women usually complain of abdominal pain or GI complaints and fatigue and shortness of breath, and this is why it's very difficult to be sure that this woman has coronary artery disease because their symptoms are very different. And of course, women or men physicians, and even a lot of women physicians think, oh, she's complaining of fatigue and shortness of breath. And when you look at our subject, we just say, well, if you put that cigarette down, you might not be so short of breath. So we would have a tendency to perhaps kind of ignore her complaints. But that stress test really says it all. You had ischemia with increased demand. Because of the failed stress test, then another diagnostic study is going to be ordered, and that's a coronary angiogram or cardiac catheterization. And again, it's really helpful if you go to these Heart Point Gallery. It's very quick. They're 2-second videos, but you can see that what a cardiac catheterization does, or coronary angiogram is, the purpose of it is to physically visualize the coronary arteries. We can get all kinds of information on wall motion with an echo, and we can kind of get an idea of what the patient is at risk for, but it's not until you do this angiogram that you really see what is truly happening within the coronary arteries. And because there are risks involved with this, we're not going to just have that patient do this test first. We're going to get the other tests done first, the non-invasive or the less invasive procedures done first, and then once these individuals fail those, then the coronary angiogram is usually ordered, because now we have a stronger suspicion that there's coronary artery disease. And you can see there's many different ways to do a coronary angiogram. Most of the time it's done through the femoral artery. So a catheter about the size of a very premature infant's finger is poked, that size hole is poked in the femoral artery, and then the catheter is threaded up backwards through the arterial system, and then dye is injected so that the coronary arteries are looked at. And this test also gives information about the oxygen levels in the blood and the different chambers of the heart, and also pressure readings from within the different hearts. So there's some other things that can be done besides the coronary arteries, but that's usually the majority of what individuals have this test for. To be able to see the coronary artery blood flow, we have to give, or the patient has to receive, IV contrast. So once this catheter is threaded, where's my arrow? Once it's threaded up this way, then dye or contrast is pushed down into the coronary arteries. And what will happen is, you can see here, these coronary arteries will light up or show, and you'll be able to see the blood flow through them. I guess Google and see what coronary angiogram looks like, because if there's blockages, it'll kind of look like those old-fashioned sausage links where you'll see clear flow and then there'll be this big gap. Again, it's a physician determination on blockages, so that's not something you have to know. Now, the contrast that's used contains iodine, and that's why if individuals have iodine allergy or shellfish allergy, such as shrimp allergy, because that's the iodine is in these shellfish, then these individuals will still have the test, because there's really no other way to visually look at the coronary arteries, but they'll get a lot of steroids and they'll get some Benadryl before the test so that they don't have an allergic reaction. The contrast or dye is cleared by the kidneys, so the renal function has to be determined to ensure that they have good renal function. Again, because conscious sedation is given during the procedure, the patient must be NPO and can't drive afterwards. As far as nursing care goes, you want to, before the procedure, you want to assess the circulation. You're poking a big hole in the femoral artery, and if there's plaque in the femoral artery, that needle that's used to poke the hole in this femoral artery can shear off that plaque, and then it can go downstream and occlude circulation. Once the test is done, our question asks, well, what about post-op care? What are the nursing considerations for post-op care? First off, post-op vitals for the post-care nurse are going to be every 15 minutes times 4. So you can imagine that once this patient, you get word that this patient is coming back to you, then this patient becomes a priority, because you're going to have to go in there and assess them on arrival, and then every 15 minutes times 4. So for an hour, you're going to have to check their vital signs every 15 minutes, and that includes their level of consciousness and their breathing ability. Remember, they got conscious sedation. And then 30 minutes times 2, and every hour times 2. And that's what I remember as the vital signs. It could vary a little bit, but you get the point that it's frequent. And then you're going to check circulation of the peripheral pulses. If you look at this picture, you can see that this leg is dusky, and what has likely happened is a clot, maybe an atherosclerotic plaque, sheared off from that femoral artery and went downstream, and you have a circulation breach, and that is a bad thing. It doesn't happen very often, but if it happens on your watch, you want to be sure and let the physician know right away, because they can go back in and put TPA in to dissolve that clot. So I digress, but I just want you to know, bad thing if you see a circulation and sensation issue and you need to notify the physician, as opposed to this leg looks really good. The other thing that can happen is the most common complication from a cardiac cath is bleeding. Again, I told you that we're poking a hole about the size of a neonate's little finger, so it's a decent sized hole in the femoral artery, which is fairly large. And if the post-procedure is not properly performed when that catheter is taken out, then these individuals can bleed either outward, as you can see here, or they can get what's known as a hematoma, which means they have bleeding under the skin. So this is a little bit more subtle when it's underneath the skin. You can see that there is this big bump, and what do you think that bump is going to look like? It's going to be very, very hard. It's not going to be soft. A hematoma is very, very firm or hard, and it's going to be painful. So these are things that you would need to watch for, and of course, because they're conscious sedation, you're going to have to do breathing. Once the cardiac cath is done, the physician will tell the patient, okay, here's the results of the cardiac cath, and in this instance, the patient is diagnosed with chronic stable angina, which means there's blockages in the artery, but nothing is severe. So there is some blockages. You have definitely a decrease in supply. So tell me, what would you expect the teaching points to be about the pattern of her illness state? Because chronic stable angina has a very specific pattern to the pain. Angina is chest pain. And here it is. The intermittent chest pain will occur over. It can happen at any time, but it will always be in the same pattern, duration, and intensity. In other words, the patient will say to you, well, you know what, I most of the time sit in my chair, but every time I get up to brush my teeth, I get chest pain. It usually lasts within a couple of minutes, and as soon as I sit down, then the pain will go away. So that's what this means. Subsides when the activity that brings on the pain is relieved. Pain at rest is unusual. In other words, it is not usually chronic stable angina is not defined with pain at rest. It is usually pain on activity because, again, we've identified that stable angina is supply and demand issue. It's only going to be when you demand more, when those myocytes demand more oxygen delivery and that narrowed artery can't supply it. And again, transient myocardial ischemia means that there will be EKG changes. The oxygen or the cell will be going, I'm not getting enough to breathe. And then as soon as you stop the activity, then that blood flow will be enough to deliver enough oxygen, and so there's no permanent damage to that muscle cell. It will continue on. And again, as I said, it's a supply and demand issue. So what will bring on that pain is, for most individuals, some kind of physical exertion or temperature extreme. When it's very hot, the pain could occur, emotional upset, heavy meals, and of course smoking. What are the critical teaching points for chronic stable angina? Well, seek medical attention if the pain changes. In other words, if you get pain when you're at rest, or if the pain occurs with activity but it doesn't stop when you stop the activity. So that would be what a worsening pattern would be. And if it wakes you up from a sound sleep, then that is also a worsening pattern. You either seek medical attention in your healthcare provider's office or go to the emergency department. Of course, this chronic stable angina it's because of atherosclerosis or a narrowing of the artery, and if this individual continues to do those bad lifestyle choices, such as obesity and drink and smoke, then the plaque formation or plaque creation is going to continue until that artery becomes even more occluded or completely occluded. So if they don't follow these lifestyle changes, then it stands to reason that stuff's going to just get worse, and you're going to have either unstable angina or acute myocardial infarction, which is a heart attack. In addition, you need to follow the medication regime. And what do you think the goals of that are going to be? Well, we want to increase the O2 demand. We need to keep those myocardial cells simmer down. We need to keep them chilled so that they don't need a whole lot of oxygen. And I don't mean chilled as in on ice. I mean they need to be decrease their demand so that there is enough O2 that is supplied to them on a regular basis. And the treatment goals of that is medication. And it stands to reason that if you think of plaque as narrowing the artery, well, therefore we need to make that artery, or have times when that artery needs to be dilated. And you know that that's what nitroglycerin does. Nitroglycerin will vasodilate coronary arteries. Nitroglycerin will mostly vasodilate venous vessels. So if an individual is having chest pain, they can take the nitroglycerin, coronary arteries will be dilated, which will help increase the delivery of more O2 to the myocardium, and because the venous system is vasodilated, less blood will return to the heart, so that means decreased preload, and that will decrease the workload of the heart. So that's another way to decrease the workload. Now, sometimes nitroglycerin alone does not do the trick, and so other drugs are added. And what I've done is put all the cardiac drugs into this simple mnemonic so that you can remember A, B, C, D. Yes, remember your alphabet. Now, we had one for another issue. What was it? Cerebral stuff? For treatment of arrhythmias. So here we go again. So don't get your ABCs mixed up. So here we go. This is the ABCD of coronary artery disease, and we're going to give A is ACE inhibitor, and those are the drugs that end in L. So that's Acupril, enalapril, captopril, all of those drugs that end in IL or RIL. What do? Well, they stop the formation of angiotensin II. What does angiotensin II does? Well, angiotensin II does two things. It vasoconstricts. And so what vasoconstriction will do will cause blood pressure to go up, but it also means that if your systemic pressure goes up, that is going to increase the afterload. In other words, the left ventricle is going to have to push out blood, eject blood into a narrowed artery, and that's a whole lot more work than if that artery was a little bit more dilated. So that's number one. ACE inhibitor will inhibit or stop that vasoconstriction, and so the blood pressure can be controlled, the afterload can be controlled, and that's reducing the workload of the heart and therefore decreasing myocardial oxygen demand. Remember, the other part of angiotensin II is that it causes the formation of aldosterone, and aldosterone is a substance that's released by the adrenals that causes you to hold on to salt and therefore water, and that's going to increase the blood volume, which again, if you have more blood in the vascular space, well, that's going to cause more work for the heart, so that's going to increase oxygen demand. So the ACE inhibitor is a big bang for the buck. It helps decrease afterload, decrease preload, controls the blood pressure, and helps with the symptoms. Now, of course, every drug has a positive because of the good things that it does, but there's always a downside to it. And so the negative of ACE inhibitors is that if the individual, for instance, is out in the summer heat and they become dehydrated and hypovolemic, the drug, you cannot do that compensatory mechanism of holding on to salt and therefore water. So this could cause them to be a little bit more profoundly dehydrated and their blood pressure can go down. And that's not a good thing to have low blood pressure and be on an ACE inhibitor. Again, you would hold the drug if the blood pressure was low, and these individuals do not want to become hypovolemic or dehydrated. When you talk about aldosterone, I said that it holds on to sodium and therefore water, but there's always a counterbalance. When with aldosterone, it holds on to sodium and water but gets rid of potassium. If I have a drug that inhibits this, that means that potassium will be held onto. It won't be diuresed or peed out like normally. So therefore, their potassium level can increase. So if they have an elevated potassium level, then you would want to hold the drug. If these individuals get what's known as angioedema or a cough, it's considered an allergy, though it's really an intolerance to the drug, and an angiotensin receptor blocker can be used if they can't tolerate the ACE inhibitor. On the B, we have B, that's beta blocker, that's an adrenergic blocker, and these are drugs that decrease the myocardial oxygen demand by decreasing the heart rate and the force of contraction. And when I ask students in the clinical setting, well, what's the beta blocker do? They tell me, well, it drops the blood pressure. Well, that's not its primary purpose. Let's remember that the beta cells will increase heart rate and it will increase myocardial contractility. The contractility goes up, cardiac output goes up. If I have a beta blocker, it will do the opposite. Heart rate will go down and contractility will go down. If contractility goes down, cardiac output goes down. If cardiac output goes down, the blood pressure can go down. And that's how beta blockers help patients' blood pressure. But the primary action of the beta is to increase heart rate and increase contractility. Beta blockers end in OL, so I've given you a list of all the OL drugs, the beta blocker drugs. And again, how does it help specifically with our heart patient? Well, think about it. We already talked about the fact that if you go up the stairs, your heart rate's going to go up because your beta cells are going to be activated and the increased contractility. Well, if your beta cells are blocked, when you go up that stair, your heart rate's not going to go up and the force of your contraction is not going to go up, which kind of means that you really won't or may not be able to tolerate going upstairs because you're going to be kind of tired. So individuals will complain of fatigue when they first go on the beta blocker, and then they seem to kind of settle down. and get used to it. Notice that because if the individual, let's say they had a worsening signs and symptoms and you know they're on a beta blocker, well, you can't do a stress test with a beta blocker on board because it blocks that heart rate from going up. And with the stress test, we want to see the heart rate go up because we want to see it go up so we can see if the myocardium becomes ischemic with increased demand. So the beta blocker has to be held if the patient's going to have a stress test. And then, of course, if their heart rate is low and the blood pressure is low, then it might be held also. C, in our alphabet of C, that's the calcium channel blockers, CCBs. Calcium channel blockers, now there's two kinds, and the kind that ends in penes, the amlodipine, nifedipine, those calcium channel blockers are responsible for arterial vasodilation. In other words, they'll prevent spasm of the artery, and this helps reduce afterload. So if an individual doesn't seem to be getting a lot of help from nitroglycerin, and not every individual will get help with nitroglycerin, then what will happen is they'll have a calcium channel blocker that is added, and of course if it vasodilates, if the blood pressure is down to begin with, then this might be held. And then D is going to be dietary considerations. If an elevated cholesterol is present, then we're going to take lipid-lowering drugs such as the statins, atorvastatin, that's Lipitor, that inhibits the synthesis. Stop taking the medicine if they develop muscle pain because this drug can cause a rare condition that causes muscles to break down, and once the muscle cells break down, then it can clog the kidneys and cause kidney failure. Because this inhibits the cholesterol synthesis, that's a thing that's done in the liver. Cholesterol synthesis is done with the liver. So because the statins inhibit that, then liver enzymes are usually checked when the patients are first put on some kind of statin. There are specific lipid-lowering drugs. I've given you a list of all the drugs. I don't want to belabor this and go through everything. Just check the sheet, the CAD worksheet, because I've put all of your drugs that were in the supplemental information in your Blackboard. I've just copied and pasted that and put it on this handout so you'll have it all in front of you. Niacin, know that that decreases the triglycerides and the LDL, so it's used in conjunction with the statins or those that are intolerant to statin. And that will also increase HDL. Patients will complain of flushing after taking the medication, it's a vitamin, so after taking the vitamin. And so if they take an aspirin or ibuprofen, that's an NSAID 30 minutes, then that flushing is reduced. If you have any questions, be sure and email me. I'm going to do part 2, which will talk about coronary artery disease, unstable angina, and myocardial infarction.